what's your assessment of the effect on the patient out there on the front lines in the community where you're seeing that patient many, many, many times a year? When you have that relationship with the prescriber in the community and there's an interaction and a dialogue and an interprofessional trust and you communicate with each other fluidly versus a scenario where you may not have that relationship or they're coming from a medical center, 2 hours away or something like that. What's the difference from the patient that you see, not only in the relationship you have with them, but also maybe even in some outcomes that you can observe over time?
It's huge, and I even see it in our staff, in that if the patient is already seeing somebody that we work very well with, we've got a lot of local prescribers that they know we do things different and we know they do things different, so we work well collaboratively. I can see us engaging patients and recommending things more often than those that we know we're not going to get a positive response or even a pickup of the phone or an answer of the fax. And so, unfortunately, it's to the detriment of that patient that we're taking care of. But that's a legit problem. It really is. The unfortunate thing is a lot of prescribers see every pharmacy exactly the same, and they're not. And every prescription doesn't have to just fall off into the dispensing abyss, which is sometimes how it seems. We went to a clinic and we were doing an in-service for their staff, and we had some of their prescribers and their social workers and community health workers. And we were talking to them about challenges and things that we could do to help and things that we did. And one of the things they said to us is, we just want to know if our patients fill their prescriptions. We have no idea if they even fill them. And so, to me, that was an aha moment, thinking, here we are, we're trying really hard, but, we need to open this communication on our end back to the prescriber too. And so that's a gap that I hadn't considered.
Well, it seems to me at the VA, you would want to know.
Yeah.
So you're a pharmacist embedded at the VA, you're working closely with folks like Dr. Morales. If that prescription goes out into the abyss, as Tripp put it, which I think is wonderfully put, what should it look like? How should it be different? What kind of relationship would you need as a pharmacist with pharmacies in the community, maybe for patients that have special support needs?
Yeah, no, that's definitely a big question, because when that prescription's initiated, you might not be seeing that patient back again for 3 months, and you're going to be able to know if they came back for their second fill. So I think that care coordination, or at least just, hey, heads up, this patient's not taking it, had this adverse reaction. In our system, and again, as many closed systems have demonstrated, the Kaisers and the Geisingers of the world, is there's obviously that attractive feature of being a closed system. And so we try to keep whatever we can in-house. And so that way, when I look into our computerized records, I can see their refill records. And so when I'm in clinic, the first things that we have our students and residents do, even before the patient comes in, is go through their medication list and look at refill records. Because they can see it's that 90-day fill, lasted 180 days, then you don't need to treatment intensify. You just need to talk to them about medication adherence and the importance of taking it on a regular basis. But I understand that that's not how easy everyone has it, and that's why I think what you're saying is so important, is that we need to have this bi-directional communication where it's not, I'm just that pharmacist because you didn't write the prescription correctly. But I think we've evolved much from that, and I think both ends see this relationship maturing and seeing that there's different levels of work and what one can bring to the table, and so I think that relationship is definitely much improved. At least I know it is in our institution.
So it sounds to me like what would be very helpful is if the expectations of community pharmacies were different for you. So if there was an expectation that there was that follow-up, and it'd be great if all of our diabetic patients followed up in 3 months. Yeah. I don't know what your return rate is in 3 months, but we all need help out there. It takes a village to take care of these patients. But when you're in clinic, how are you helping a practitioner like Dr. Morales? What are some specific services that might be there for the patient where you're working as a team?
Sure. So the way our clinic is set up is we have a team. I sit within an endocrine clinic, and so we have 3 endocrinologists, myself, and a nurse practitioner, and that's what makes up our core team. And then we obviously have the ability to refer to nutrition, dietitians, social work, all of our other care team members, but that consists of our core unit, and we take referrals and consults from all of our primary care colleagues. And so, a typical day, we carry our own panel of patients, very similar to what a nurse practitioner or a PA would be doing, but then we're also available for any warm transfers. Mm-hmm. Dr. Morales could see a prescription, decide I'm starting this patient on, insulin. He needs to know a little bit about hypoglycemia, how to inject it, and how to use a meter. Well, his time probably could be used a little bit more effectively by, seeing another patient, making another diagnosis. And so for those, we'll take the warm transfers. And so we'll make sure that we show them the first, injection in clinic. We'll do a demo for them. We'll even have the students go downstairs and pick up their supplies, and we'll actually have them practice on their own supplies if it's the first time. But it's that additional time that's needed where they can't fit it into a 15, 30-minute, or in many cases for us, it's a follow-up, right? So if he were to start insulin today, the patient needs to get titrated sooner than the next 3-month appointment, so on that follow-up, I would be that two-week follow-up where, hey, I wanted to see how your blood sugars are, averages, and if I need to, I can talk to the provider. Mornings are still high, we're gonna go up, or, and so in between the visits, we, kind of close that gap as well.
Well, it speaks to, if you're in an endocrinology clinic, the intersections as well. So if you're needing to titrate on the anti-diabetic medications with a cohort where there's comorbidity, high comorbidity rates with depression, same story, right?
We see it all.
And there's a need for a titration, there's a need for how do we get to a stabilized result, because that first prescription out the door is not necessarily where you're going to land 3, 9, 12 months down the road.